Good morning, everyone. Welcome to Healthcare for All Minnesota's quarterly meeting. My name is Dana Koltar. We are going to get started. We have a number of speakers this morning. So I'm your host. I'm the administrative support for Healthcare for All Minnesota. We'll have a presentation from our chair, Dr. Mark Brakke. We'll have a report from our secretary treasurer and our board liaison for our legislative committee, Don Pylkkanen. We'll have an update from Rose Roach, executive director of MNA and board member of Healthcare for All Minnesota. Our featured presenter will then speak. His name is Dr. Gordon Mosser from the School of Public Health. And we'll also have our vice chair, Ann Jones, who will be presenting on education and outreach. And I think that's it. So that was in general the order of our agenda, and you can see on the slide in front of you what our agenda will be. And then I will be doing a wrap up at the end. After Dr. Mosser's presentation, there will be a Q&A. Those questions will be submitted, should be submitted through the Q&A box at the bottom of your screen. So we'll go ahead with Dr. Brakke. We'll get him on.
Good morning. We appreciate you all taking time this morning to join us to talk about a subject which is important to all of us. We know that one of the major inequities in the United States is the lack of universal affordable health care. If an economically successful nation is not willing to provide a living wage, affordable housing, and universal affordable health care for its citizens, it is clearly not a very just society. George Floyd died because he was the victim of a society which still sees many of its citizens as inferior. That is clearly unacceptable. Thank you all for your commitment to making the U.S. a more just and more equitable society by trying to solve the problem with the way we finance our health care. We could talk about examples of the dysfunction of the U.S. healthcare system or non-system, as we know it is, all day. We could talk about this all day and not run out of material. I'm only going to mention a few. How clever is it for us to have employer-based healthcare when there is a pandemic? So far, 6 million employees have lost their health insurance, which means there are an additional 12 million uninsured U.S. citizens with the pandemic. You add that to the 20 million or so which were previously uninsured, and many millions more who are underinsured, and the magnitude of the problem is quite daunting. Another example of the dysfunction in our system, insulin. Insulin glargine, a commonly used insulin, costs, if you go to buy it for cash at the pharmacy, about $306 per 10 cc vial in the United States. In Canada, that same insulin can be purchased for under $40 a vial. What kind of a society allows a ridiculous pricing problem like that to continue to exist? And then take a look at CEO compensation. I will just mention one example, although there are many. In 2018, Kenneth Fraser, CEO of Merck, had $20,900,000 in total compensation. If instead he had been paid $1 million in compensation, which most people should be able to live satisfactorily on, the remaining dollars could have purchased insurance for over 2,700 of the citizens of the United States. What is the logic in a healthcare CEO making that kind of money when millions cannot afford their own health insurance premium? Well, I'm happy to let you know that Healthcare-for-All Minnesota has been continuing to work for healthcare finance reform even during the pandemic. We are producing webinars, talking to friends and neighbors, and working to strengthen our cooperation with other organizations which want to achieve single-payer healthcare. If you went to Wikipedia, you can actually find a page on which they list organizations in the United States which are seeking healthcare finance reform, and the list is very extensive. One of the new initiatives that Healthcare-for-All Minnesota has is developing an active Instagram page. We have 2 energetic University of Minnesota seniors in engineering who are helping us turn this from an idea into a reality. This is a good way to reach a younger audience, and that is important for the work we're doing. We will soon be sending you an email with further information about how you can help support the Instagram initiative. You are also going to be hearing about other work that HCAM is doing as the program progresses. One other item I would like to mention regarding what we're working on during the pandemic is what we call our member-powered member drive. Several weeks ago, we sent out an email asking for your help recruiting new members. Please keep this in mind. Getting on our email list is easy. All one has to do is go to the web page, and in the center, there is a green button which says, Get Our Updates. If people will click on that button, they will be given the opportunity to enter their contact information, and they can stay up to date on what Healthcare-for-All Minnesota is doing. So I would encourage you to help your fellow Minnesotans get universal, affordable healthcare by guiding your family, friends, neighbors, and casual conversation encounters to our webpage. Finally, a word about the upcoming election. Healthcare-for-All Minnesota does our best to be nonpartisan, but that does not mean we are forced to be unrealistic or accept falsehoods. We are allowed to oppose candidates who are not supportive of our organization's goals. Losing the November 3rd election to the current administration is as close to an existential threat to our democracy as anything I have seen in my lifetime. I suspect you all feel the same way. The most important thing we can all do for the future of democracy in the next 66 days is to support rational candidates at the state and national level who will work for the good of society, not for the enrichment of the wealthy. If we do not succeed in electing a progressive government, we will not see healthcare reform. Each of us must do all we can to get progressive voters to the polls. The next 66 days is critical. I am sure you will all be doing your duty. Thank you for listening to these comments. I will turn you back over to our manager, Dana.
Thank you, Mark. Next up is our treasurer's report from Don Pylkkanen, and he'll also discuss the next agenda item, city council resolutions. So we'll get Don on video here. So Don, you need to unmute.
There, I unmuted, and I understand there's from what Dana told us yesterday in our rehearsal that there's about 90 folks out there that I can't see. But anyway, good morning, and thanks, Mark, for laying out the costly perversities. I'm trying to say perversities in the current for-profit system that we're up against, and we're up against a $1 trillion industry trying to raise money to counter it. And so it really makes our work daunting, but I think it's worth it because it's the right thing to do. We don't have a choice but to fight this massive perverse health insurance industry. So it's good to see more supporters using the new and easier online credit debit card button on the website, which has raised $620 from 30 donors since the July or June quarterly meeting, which averaged $20 to $21 per donor. So HCAM thanks you for your support. For those who haven't tried it, excuse me, go to the contribute button on the right side of the home page, which brings up the donation page where you can quickly click on the contribution amount and fill in the contact and debit credit card payment information. In addition to these individual donations that I mentioned, I'm pleased to report that since the June 6th meeting, the following large amounts came in. $1,000 from tabling at the July 11th Global Rights for Women event at Crooner's Supper Club, $5,000 from the Joan of Arc Justice Fund Grant, and $1,000 from the Minnesota Nurses Association. To make it easier for making online tax-deductible donations directly on the website, as you now are using the function for directly contributing to the 501c4 HCAM, you'll be able to do tax-deductible donations more directly rather than going through the COACT Education Foundation, because Bruce Larson got HCAM's own education foundation incorporated in the state of Minnesota for you to hopefully soon to contribute to when we complete the application process for getting the IRS 501c3 status for it. This will also be needed for getting grants from foundations, which requires 501c3s. Meanwhile, you can still get a tax deduction by writing your check to the COACT Education Foundation by putting for HCAM on the memo line. As I was getting at earlier, we're really up against it with a behemoth trillion-dollar industry. And years ago, Paul Wellstone said that going up against the health industry in our society is like going up against the military-industrial complex. So we need to keep raising money for expanding the statewide campaign with new groups who are coming in, who are committed to the Minnesota Health Plan and Medicare-for-All. This will require hired staff for community organizing, research, and social media work, along with paying for rent, telecommunications, travel, printing, postage, publicity, and so forth. Mark, Bruce, and I figured that those expenses add up to $154,000 to fund the first year of the expanded statewide campaign that the board is looking at. And this is compared to the $30,000 that we now have in the bank. This means increased funding from individual donors, major contributors, and foundations. The expanded campaign with more groups committed to the Minnesota Health Plan and Medicare-for-All makes this added work worthwhile. Thank you. And now I will proceed to the update on the city resolutions campaign. And that for us really got a boost from the St. Paul City Council, who you see on the screen. Local governments in Minnesota and across the nation deal most directly with our unaffordable, inequitable, and for-profit and perverse healthcare insurance system, which is failing to protect the health of their employees, residents, and Main Street businesses. Therefore, a growing number of city councils are endorsing the Medicare-for-All Act. The Minneapolis Council endorsed it earlier this year, and the St. Paul Council unanimously and enthusiastically endorsed it on August 5th, along with the Minnesota Health Plan and the Federal Healthcare Emergency Act due to COVID-19. Minnesota's two largest cities join Los Angeles, San Francisco, Seattle, New Orleans, and Ann Arbor, and many other cities which have already endorsed Medicare for All. And folks in one-payer states, like here in Minnesota, are advancing state single-payer plans as an alternative due to the gridlock in Washington over Medicare for All. So Canada's province-by-province method might be the way to go. Either way, single payer is long overdue. The St. Paul resolution was sponsored by Council Member Nelsie Yang and came from HCAM. The resolution came from HCAM, Minnesota Nurses Association, PNHP Minnesota, and Twin Cities Democratic Socialists. Thanks to MNA's Rose Roach and to Linda Gridley for getting Nelsie Yang to sponsor the resolution, and to Rose for recruiting two great testifiers. Stella Obadiah, lead nurse at Bethesda Hospital, and Dan Marshall, co-owner of Mischief Toy Store on Grand Avenue here in St. Paul. Failure of the current healthcare system to protect the public from COVID-19 was a big reason for the council's unanimous vote, along with Stella's and Dan's testimonies on corporate control over our healthcare based on profit making, which has created high costs and economic and racial disparities over who gets medical care. Following St. Paul's endorsement, Steve and Joan Janis and members in Northfield and Mark Friedman and members in Mankato are working with their council members to pass the resolution. And word came in that Burnsville folks are also working on a resolution. So a Zoom gathering is being planned for these folks, Steve and Joan, Rose and Linda and Mark, to share their work on the resolution with those folks of you who want to work for it in their cities. The basic steps are very straightforward. Review the resolution and localize it for your city regarding their budget needs and the numbers of residents in their cities and area that who are uninsured, and other problems coming from our current system. Finding a council member to sponsor the resolution, finding 2 or 3 testifiers like Rose did, as I just reported on, and getting word out to local supporters to attend the virtual council meeting, for which HCAM's listserv can help contact supporters in the respective cities. So stay tuned for the announcement and the link for the Zoom gathering on the resolution campaign as we head into the fall. Thank you.
Thank you, Don. I will mention here that anyone who registered for this webinar will be getting a post-webinar email with a number of resources, links, further information on topics that we're discussing during this webinar. We did have one question about how do you get notified about this upcoming Zoom meeting. I would imagine we would be sending something out to our full list, and you would be able to join that way. Okay, thank you again, Don. Next up, we have Executive Director of Minnesota Nurses, Rose Roach.
Thanks, Dina. Good morning, healthcare justice warriors, and greetings from your nurses of health and solidarity. So I'm going to touch on a couple of things from the field real briefly, sort of where things are at on the fight against the pandemic, a little bit about Insulin for All and the National Nurses United Medicare-for-All national campaign, and then a few words about the Democratic National Committee's platform committee and the fact that they voted down putting Medicare for All in the Democratic platform. So going on to COVID-19, our nurses are continuing, unfortunately, to deal with immense stress that's caused by potential COVID exposure and the fear of bringing something home to those whom they live with. They have a continued fear of being furloughed or laid off. For those that are still working, many are dealing with survivor syndrome, the financial stress from family members being out of work, and like the rest of us, balancing work and childcare school responsibilities are top concerns for their personal safety and the safety of their family. Nurses also are facing ever-changing guidelines about what's safe, things such as levels of their personal protective equipment, this idea that you can decontaminate N95 masks and reuse them over and over again. We recently heard from the nurses in New York where they are receiving boxes of N95 masks that have they look like they're new and they're actually reused. The FDA has recently issued an advisory that states that the non-negative pressure protective barriers, which were touted as protecting healthcare workers from potential exposure, are now deemed to be unsafe. So this is an ever-changing, moment-by-moment situation, particularly with pressures out of the national administration against on the Center for Disease Control, and the testing, the use of PPE, the production of it, it continues to get weaker and weaker, and it's become a really serious problem for the nurses and healthcare workers inside of the hospitals. Hospitals are, no surprise here, using the pandemic as a cover for financial woes, which are resulting in an enormous amount of concern amongst nurses about employment stability. I'm going to provide Dana with some NNU, our National Nurses United affiliate, research on decontamination and the reuse of N95s. It's pretty straightforward in layman's terms, but it gives you an idea of what the nurses are having to deal with. And then also the new FDA advisory regarding the non-negative pressure protective barriers. In regards to Insulin for All, I think everyone knows that the Alex Smith emergency insulin bill did pass our legislature and was signed into law. It became effective July 1st. And hours before it became effective, of course, Big Pharma stepped in and sued the state of Minnesota to stop this from happening. However, the law became the law. They were not able to stop it and get an injunction to stop the law from becoming effective on July 1st. So that law is in effect. And thankfully, Attorney General Ellison has this case on behalf of the state. And in talking with him, he believes that we are in a really strong position to be able to prevail. I want to mention on a side note, I think most of you know that I was honored to serve on the Attorney General's task force on lowering pharmaceutical drug prices. And we just have been informed that our report actually won a National Notable Document Award from the National Conferences of State Legislatures. So I'm very proud of this work, but I just wish the state legislatures would take it seriously, look at it, and start to implement some of those bills and get those laws passed. We'd be in a much better shape around pharmaceutical drugs. From NNU and the Medicare for All National campaign, as again, many of you may know because you participated, and thank you for doing that. A week ago today, there was a national action, whereas HCAM was the lead in the Twin Cities area in particular, doing multiple sign holding actions around the Twin Cities area. There were over 200 actions that took place across the country supporting Medicare for All. The nurses are using the new modes of communication, like we are, due to the pandemic, to provide various town halls and forums on Medicare for All. And they are also engaged in a very successful nurse texting campaign in the swing states. They are using Medicare for All as a hook to engage nurses in conversation and then tying them to their state's congressional candidates who are endorsed by National Nurses United because they support Medicare for All. So this has been an enormously effective way in which to engage nurses about this issue, and it also engage them in the electoral political situation. Now a few words about the Democratic National Committee's platform committee. So I'm not sure if everyone knows or not, but there are two Minnesota representatives, State Senators Melissa Franzen and Fong He, who were on that platform committee, and they voted no on adding Medicare for All to the platform, although they personally, as Minnesota legislators, support both Medicare for All and the Minnesota Health Plan. According to each of them, they have said that they served on the committee as Biden representatives, and the Biden campaign basically dictated how they voted, and they were told to vote no on adding Medicare for All to the platform because VP Biden doesn't support it. So the MNA nurse leaders got together with both of these state senators to express our frustration and dismay of their vote, to listen to what they had to say. And I am pleased to let you know that of the two of them, the Senator He has now said that at the next session after his reelection, he will be signing on as a co-author of the Minnesota Health Plan. So that is certainly a positive development. As a labor leader, it was particularly disappointing to see leaders from three unions, national unions, who supported the Medicare for All Act of 2019, yet they voted no on adding Medicare for All to the platform. I'm going to also provide a link in the chat to a really terrific article by Mark Dudzik. He's the national coordinator for the Labor Campaign for Single Payer, of which I'm a steering committee member of, and he does a nice job of spelling out, you know, our disappointment and why that was not something that labor should be doing in regards to the platform in the Democratic Party. We should be all supporting Medicare for All. And then finally, I will note that when the convention itself took place a little over a week ago, 1,069 delegates at the Democratic National Convention voted no on the party platform for failing to include Medicare for All and other critical progressive solutions. And that did include Biden delegates as well as Sanders delegates. So there is crossover there around this issue without a doubt. So I feel like if nothing else, there was certainly a strong message that was sent to the party in general. So that's my report. Thank you, everyone.
Thank you so much, Rose. All right, next up, we have our featured presenter, Gordon Mosser. He's a senior fellow at the Division of Health Policy and Management at the School of Public Health. He will be presenting today on what will Medicare for All really cost. So Dr. Mosser, we got to get you up on video here.
Okay.
Oh, there you go. And if you want to get your presentation shared.
How are we doing? Is it up?
Yes, it is. Thank you.
Okay. Now, do you want to show me on video or not? I don't
Yes,
see.
you are on video. You're on video right now.
Okay. Good. Well, thanks very much for the introduction, and thank you all for the opportunity to speak with you today and share some work that I've done recently. The title that you see here is what I'm going to talk about. Reports, all of them actually, that have been done on the cost and funding of Medicare for All. So first of all, let me be clear, this is hardly necessary with the folks who are participating here, but so I'll be very brief. Medicare for All is a new way of organizing funding for all of U.S. healthcare, public health related activities, everything connected with healthcare at the federal level. It's not an addition to what's going on now. It's a wholesale replacement of what's going on now. All payments to hospitals, physicians, physical therapists, pharmacists, et cetera, would come from the federal government. Private insurance would be prohibited, and all Americans would be covered. There is still some uncertainty as to whether undocumented immigrants would be covered. The two bills before Congress are not explicit about that. There wouldn't be any form of cost sharing. So no co-payments, no deductibles, no maximum payments per quarter or per year, no co-insurance, nothing. New benefits would also be added. Most important of these, I think, are dental care, eyeglasses, hearing aids, and long-term care. And although this is kind of dull, it's very important that there would be a single unified national health budget. The budgeting process then would assure that there are direct discussions about trade-offs and allocation decisions between clinical care and public health and research and anything else to do with healthcare. The VA and the Indian Health Service would be included in this budget. They would probably be administered separately, but again, the bills are not totally clear on that. If you want to know more, you can look to the bills themselves. HR 1384 is the one for which Jayapal from Seattle is the first author, and Senate 1129 is Bernie Sanders' bill. So that's what I'm talking about here. And I assume in this talk that the US needs Medicare for All, and that the principal reasons for enacting it are to improve the health of Americans who are currently uninsured or underinsured, and to spare everybody financial hardship caused by the need for health care. Those aren't the only reasons, of course. The bill would, or the program would have the purposes of cost control and elimination of healthcare inequities and various other things, but those principal reasons and are the crux of the case for Medicare for All. In this talk, I'm not going to make the case for Medicare for All. That may well be a more important topic than what I'm talking about, but I'm focusing on something else, which is to provide an answer to something that people commonly say or hear in discussions of Medicare for All, something along the line of, maybe in a perfect world, we would have healthcare for everyone without cost, but we can't afford it. And what I aim to do here is provide you with an answer to that statement. So the questions that I will address here are three. First of all, how much will US healthcare cost under Medicare for All? Second, how much new federal revenue would be needed to replace the money that will cease to come from households and insurance companies, where it comes from now? And third, how might this revenue be raised, which is something I will deal with only briefly. Now, the phrase cost of Medicare for all invites misunderstanding. It echoes the phrase cost of Medicare, which in 1963 and 4, we heard a lot about. I was around then. And it made sense then. Medicare was proposed as an addition to US healthcare, and it had a cost, still does, and that cost increased the cost of US healthcare because it was an add-on. But Medicare for All is not an add-on, it's a replacement of the whole. And so, under Medicare for All, US healthcare could, in theory, cost more or less than it does now. But there will not be an add-on cost because nothing's being added on. If the phrase cost of Medicare for all means anything, it means the cost of US healthcare under Medicare for all, because there isn't a separate program to talk about. And hopefully this chart helps to make things clear. Right now, the whole of the provision of healthcare, hospitals, physicians, drugs, and so on, is paid for by individuals and families, rather small arrow, narrow arrow as you see, quite a lot by the federal government, larger arrow, almost the same amount, but not quite, coming from private health insurance, and then state and local governments also providing some. After Medicare for All is enacted, nothing will come from individuals and families, and nothing will come from private health insurance. I quite enjoyed making this X, by the way, crossing out the box for private health insurance. And state and local governments will continue to provide some, specifically for public health and general assistance, but less than they do currently. So in order to provide the money required, the federal government will need to provide a great deal more than it does now. And you maybe can see that this dark pink box here is slightly smaller than the current pink box, meaning that the cost of the whole system, and this is what I'm going to show you here, is less than the current system. But despite that fact, the federal government will need to provide a good deal more money, indicated by this black arrow. So it sounds paradoxical. Total cost down, but federal government expenditure up in order to replace the money coming currently from individuals and families. And by the way, this chart is not complete. It doesn't include small amounts coming from employers directly to hospitals, physicians, and others, as in worksite health. And it doesn't include philanthropy. In 2018, a non-trivial amount for clinical care, namely about $150 billion came from private philanthropy, and that's not included here either. Those amounts in the grand scheme are small, and the four sources I've shown here are the main ones. Okay, so this slide and the next one indicate the methods I used in doing my review. First, I identified reports that answered the three questions: how much will U.S. healthcare cost under Medicare for All? How much new federal revenue will be needed? And how might the revenue be raised? And I identified the reports by doing a variety of searches. The standard medical search through PubMed doesn't yield much. And so, because most of the reports are not published in standard healthcare or medical literature. So I had to look at various newspaper reports, magazines, just website searches. So having identified the reports, I listed their methods, their assumptions, and their conclusions, and then did some evaluation of the reports to be able to set aside any of these reports that had deficiencies important enough to warrant not including them in answering question number one, namely, how much will U.S. healthcare cost under Medicare for All? And then averaged the increases or decreases in cost under Medicare for All from the remaining reports, in other words, the ones that were not set aside, to get to an overall percentage change figure. And then using CMS or Medicare's projections for healthcare costs under the current system over the next 10 years, apply that change percentage in order to get an estimate of how much U.S. healthcare would cost under Medicare for All. So now we know what the cost would be. Next step is to identify all the current revenue streams that would continue under Medicare for All. For convenience, I refer to these as old revenue. They're things like the current payment for Medicare, payments for research, public health, and so on that we can expect to continue. And then calculate the new federal revenue needed by subtracting the continuing or old revenue amount from the cost of U.S. healthcare under Medicare for All. And then, in order to look at the question of how to raise the money, listed all possible taxes and fees that could be used to raise the new revenue, and then finally selected taxes and fees sufficient to provide the revenue that's needed. So it's a pretty straightforward logic. Get clear on what the need is, figure out how much revenue we can count on continuing from the current arrangements, subtract that from what's needed, coming up with the amount of new federal revenue needed, and then look at options for raising that revenue. So these are the reports I identified. There are only 7 from 2003 onward. Why do I pick 2003? Because that was the year in which John Conyers submitted his bill for Medicare for All. He didn't call it Medicare for All. It was a single payer, I think was the phrase he used. And it's since then that we've had a standard definition of what the program is. There are reports on the cost of single payer going back as far as Ted Kennedy's effort in 1971, but they look at different programs, so they're not really comparable. And yet, from 2003 onward, everybody's working off the same definition. So the reports are first one by Kenneth Thorpe, a professor of economics at Emory University, and his focus is on how much new federal revenue would be needed. Then one from Charles Blehaus at the Mercatus Center at George Mason University. This center is a rate of center think tank that produces any number of reports on free market approaches to handling the US economy. The third one is the usually called the Perry Report, Political Economy Research Institute. It's at the University of Massachusetts in Amherst. First author is Pylkkanen. And this report is very extensive, 250 pages. It deals with really any issue connected with Medicare for All that you might think of. The next one is by Gerald Friedman, who is also at the University of Massachusetts Amherst, but interestingly is not an author of the Perry Report. He wrote his own. Then the Urban Institute, which is a very prestigious private policy research organization that does reports principally on social legislation issues and healthcare. And then the RAND Corporation, also very prestigious, headquartered in Santa Monica. They do policy reports on a wide variety of issues, including military issues and diplomatic issues. And they produced a report last year. And then finally, early this year, Allison Galvani and her colleagues at Yale produced a report. So we've got 7 altogether to look at. Now, some comments about the methods of these reports. All of them seek to take into account the factors that could increase or decrease cost under Medicare for All. All but the Urban Institute report begin with Medicare's or CMS's projections over the next year or 10 years, and then modify those projections of healthcare costs for the factors that could increase or decrease the cost. The Medicare projections are used by everybody in healthcare economics. They're highly reliable. They're not biased. They're not, by the way, projections of how much Medicare would cost. They are projections of how much U.S. healthcare could cost, and they're sliced and diced in many ways. Each of the reports has, I don't know, 50 tables or so. Very useful source of information, and that's the starting point for nearly all of these reports. The Urban Institute report is different. Instead of using Medicare's projections, it uses a computerized microsimulation model. In other words, it takes findings from health services research and then seeks to project how the behavior of institutions and individuals would change with different coverage and different payment levels, and project forward that change in behavior together with a few other assumptions in order to come to their conclusions. Other assumptions include, most importantly, how much hospitals and physicians would be paid. That's an administrative and political decision which can't be simulated on the computer. So Urban Institute report makes some assumptions in those respects. All of the reports make assumptions about key factors affecting cost change. And the most important of these are utilization, in other words, demand for health services under the provisions of Medicare for All, insurance administrative cost, how much does it actually cost to run the program, both before and after the institution of Medicare for All, the cost of drugs, and finally, the payment levels to hospitals and physicians. Where might there be savings with Medicare for All? Well, there are three principal areas. The first is elimination of private insurance administrative expense. Currently, private insurance pays 13.2% of premiums on administration. Medicare, traditional Medicare, pays 2.3%. So there's a huge difference, and that's the source of most of the potential savings with Medicare for All, because the private administrative expense would be replaced by Medicare expense. The second source of potential reductions is in prescription drug expense. This would be achieved by between Medicare for All, the new Medicare authority, and the pharmaceutical companies. Some of you may not know that currently it is actually illegal for Medicare to negotiate with the drug companies. An outrageous arrangement achieved by forceful lobbying at the time that the Medicare drug benefit was established in 2005. That restriction would be removed, of course, with Medicare for All, so that drug expenses could be negotiated downward. And finally, there could be decreases in payments to hospitals and physicians, and that would be achieved by Medicare for All by fiat, by diktat. Medicare doesn't negotiate prices. Medicare simply states what the prices will be, and or the payments will be, and Medicare for All would do the same. Now, the writers of these reports actually don't expect that that the payments will be decreased, and so that turns out not to be a source of savings in these reports. Now, you may have expected to see here a decrease in cost savings resulting from hospitals and physicians not needing to deal and dicker with multiple private insurance companies anymore. And indeed, they would save money by not having to employ these armies of clerks to do this work. However, please note that this is not actually a savings to the whole system. The current payers for healthcare, private insurance, federal government, and so on, don't pay the clerks who are doing this work. They are paid by the hospitals and physicians. So if that work goes away and therefore there's a savings to the hospitals and physician offices, that's a savings to them, not to the whole system. And that would result in savings to the whole system only if payments to hospitals and physicians were decreased accordingly. And said that's not something that the writers of these reports expect to happen. So what are the assumptions of the reports with respect to the key topics? With respect to utilization, Friedman's report expects an increase of 2.9%, the Rand Corporation 3%, Yale 8%. You see the rest of the figures on the slide here. The Urban Institute, interestingly, does not state what it thinks will happen with utilization. I will come back to that. And the Rand assumption is really 6% because they deal with only the first year after Medicare-for-All is enacted, and they state that they expect the delivery system to be able to handle only half of what the increased demand for utilization would be. So 3% is half of what would otherwise be 6%. So Rand, Yale, Thorpe, Playhouse, Perry, they're all in the ballpark, 6, 8, 10, 11, 12%. With regard to insurance administrative expense with Medicare-for-All, we currently have, as I've said, 2.3% for Medicare, traditional Medicare, and 13.2% for private insurance. Friedman projects that after the change, the administrative expense would be 2% overall, Yale 2.2%, Perry 3.5%. Again, you can see the figures written here. The highest are in the Playhouse and Urban Institute reports at 6%. With respect to drug costs, Rand projects that drug costs would end up being 10% below what they are for Medicare now, although and I don't know what that is, so I'm not sure where that ends up. Playhouse anticipates a 16% reduction. The Perry report projects a 40% reduction, and you see what Yale says. The Thorpe and Urban Institute reports actually don't make any statement about drug costs. With regard to hospital payment, Medicare rates are projected by Playhouse, Perry, and Yale. For hospitals, Medicare plus various additions. For the other reports, Thorpe expects Medicare plus 18%, Friedman Medicare plus 10%, Urban Institute Medicare plus 15%, and Rand, amazingly, Medicare plus 24%. So as you see, payments to hospitals are not expected to decrease. And keep in mind that the hospitals would get a substantial, about 5% of their revenue improvement in bottom line because they wouldn't have the cost of having to deal with all these insurance companies anymore. So they're going to end up fine according to what happens to what is stated in these various reports. Physicians are projected to be paid at Medicare rates, and they would, because of the improvement in their cost position, no clerks needed to deal with insurance companies, experience a 7 or 7.1% projected in the Perry report improvement in costs. So they would come out about the same. Sorry, I'm not being clear. Currently, physicians are paid a good deal more by private insurance companies than they are by Medicare. If they were paid Medicare rates for everything, they would sustain about a 7% reduction in revenues, but they will experience a 7% improvement in costs, so they would come out about a level. The RAND report anticipates a 7% increase over Medicare, and say about physician payments. So there you see where the reports are on these various assumptions. Here's where they come out with regard to the important bottom line figures. With respect to change in the cost of U.S. healthcare in the first year after Medicare-for-All is enacted, Friedman projects a decrease of 20%. The Urban Institute projects an increase of 20.6%. With regard to the cost of U.S. healthcare over 10 years, Friedman projects that the cost would be $37.2 trillion, and the Urban Institute projects a cost of $59 trillion. Medicare, the CMS projection figures currently are $49 trillion. So Friedman would be substantially under, and the Urban Institute substantially over. The change in cost over 10 years with Medicare-for-All projected to be down 20.6% by Friedman and up 13.5% by the Urban Institute. And the new federal revenue needed over 10 years is projected to be $13.5 trillion by the Perry report and $34 trillion in the Urban Institute report. And by the way, recently Biden stated that Medicare-for-All would cost, and what he meant was U.S. healthcare under Medicare-for-All would cost $59 trillion. So he chose the figure from the Urban Institute report, which for my money is deliberately misleading. He could have chosen the Friedman report, which would have been $37.2 trillion, or the Perry report, which is only slightly higher. And both of those figures are less than what CMS currently projects. The only one in the whole series of reports that's higher is the Urban Institute figure of $59 trillion, and that's the one he chose to speak about publicly. I hope this chart will help explain why the cost of Medicare-for-All is not the same thing as the new revenue needed. In the Playhouse report, the current system is projected, without Medicare-for-All being enacted, at $59.6 trillion over 10 years. And he projects that with Medicare-for-All, the cost would be $57.6 trillion. In other words, despite coming from a right-of-center think tank, he thinks Medicare-for-All would cost less than the current system, a little bit. He projects new federal revenue needed would be $32.6 trillion, meaning that the old revenue continuing would be 25. So here you see that the new federal revenue is not an add-on to the current system, and it isn't the cost of Medicare for U.S. healthcare under Medicare-for-All. It's revenue that covers part of the cost of Medicare-for-All after the change. Similarly, the Urban Institute projects that the current system would cost $52 trillion over 10 years, and that Medicare-for-All would cost more, in other words, $59 trillion, as I said earlier, over 10 years. And the new federal revenue, as you see again, covers part of the cost of Medicare for all, in other words, the system under Medicare-for-All. Now, you might wonder, how can one author project current system would cost 59, nearly 60 trillion over 10 years, and another one project 52 trillion? That's because they're using different 10-year periods. I don't know why the Playhouse chose to start his 10 years, 4 years into the future. Perhaps he thinks it would take that long to get things going. I don't know. But that's the reason that the current system cost estimates are different. So now to my own conclusions about Medicare for All's effect on cost. First of all, as I said, I provided some critique of the reports. Now, Gerald Friedman is a favorite, understandably, of proponents of Medicare for All. He was Bernie Sanders' principal advisor on healthcare in the 2016 campaign. And he's very enthusiastic, very persuasive, but I believe he exaggerates. His utilization increase projection of 2.9%, simply due to covering more people, never mind dropping copayments and so on, just doesn't seem plausible. There's about 10% of the population is not now covered doesn't have insurance. And so to increase the percentage of people covered and experience only, this 10% of the population experience only 2.9% increase, not very plausible. Also, he states that the current private insurance administrative cost is 20%. Well, Medicare says it's 13.2%. Himmelstein, who's many of you know, has been an advocate of Medicare for All or single payer for what, 30, 40 years, estimates that private insurance administrative cost is 12.2%. 20% is way high higher than anybody else projects, and not plausible. And Friedman counts as savings to the whole system the savings experienced by hospitals and physicians' offices not having to deal with multiple insurance companies. So in several respects, I mean, my heart's with him, but I think he's exaggerating how much savings can be achieved. And he ends up concluding that Medicare for All will cost 20% less than the current system. This is nearly twice what anybody else projects. So for that reason, for his reason of his exaggerations, as I'm calling them, I've set his report aside. The Urban Institute story is a little more complicated. It projects that hospital costs or payments will remain about the same. Physician payments will go down a little bit. Drug costs down a lot. Administrative costs for insurance down a lot. And yet the cost in the first year would go up by a little more than 20%. Well, if all the unit costs are decreased, or in the case of hospitals, about the same, and the cost has gone up, that could only happen if utilization went up very substantially, more than 20%. That's not plausible. I mean, I have a guess as to how they came to that, but it's just not plausible. And for that reason, I have set their report aside. The Thorpe report doesn't have any cost figures in it. So this leaves 4 reports with figures for decrease in cost in the first year, and they're listed here. 3 of them have costs decreasing, and the RAND report has it costs increasing just a bit. And if you average all of those, you get a savings of 5.7%. So that's my bottom line conclusion as to how much Medicare for All would save us. So the cost is projected by CMS of US healthcare over 10 years would be 49 trillion. If you take away 5.7%, you end up with $46.2 trillion over 10 years. The continuing revenues would come in 4 different streams, and I'm not going to go into the details, but a large chunk of it, of course, comes from the federal government for clinical care and public health. It also pays for some other things. State and local governments would continue to pay for public health. They do cover 90% of what's paid for public health currently. There would be continuing revenues for investment in CMS's terminology. That means research, buildings, and equipment. And finally, there'd be $1 trillion from other third-party payers, an obscure CMS term. It includes the Indian Health Service and various other fairly small amounts of money. the total of continuing revenue would be 22.6 trillion. So if the need is 46.2 trillion and you've got 22.6 trillion available from continuing old revenue, the new federal revenue needed would be 23.6 trillion. And numbers on that chart I showed you earlier, currently nearly $5 trillion comes in out-of-pocket payments from individuals, households, families, going directly to hospitals, physicians, and so on. The federal government currently pays 19.3 trillion over 10-year period. Private insurance a little less, 16.1 trillion, and state and local governments 5 trillion. And after the change, nothing would come from individuals and families, nothing from private insurance. So the federal payments would increase by 23.6 trillion, as I just showed you, up to 42.9 trillion. 1.4 trillion would continue to come from state and local governments. And if you're very quick with arithmetic, you will have noticed that these four figures here don't add to 49 trillion. That, as I mentioned again, that's because payments directly from employers and from private sources, in other words, philanthropy, are not included. They're fairly small amounts, but in any case, they're not included on this chart. Back to the cost of care versus new revenue. Most people who are considering the topic of how much would U.S. healthcare cost under Medicare-for-All are concerned about the cost. But there are some people who are actually more concerned about the amount paid by the federal government than they are about the cost. In other words, they're concerned about this big black arrow here, which represents, and they're right, a great increase in the influence of the federal government over healthcare. And they are more concerned about that than anything else. Thorpe, for example, wrote a paper ostensibly on the cost of healthcare under Medicare-for-All. He didn't say anything about what the cost of healthcare under Medicare-for-All would be. All he talked about was the amount of federal revenue needed. I assume that he's one of these folks who's most concerned about how much the federal government will be paying. Who are these folks? Well, they are the folks who are proponents of small government and low taxes, who have been particularly prominent in our political scene since Reagan. Of course, they've been with us for much longer than that, but especially since Ronald Reagan, they've been very prominent, and their concern is the size of the federal government. So even if you can give an answer to some of these folks who say we can't afford it, you will discover that some of them aren't really concerned about that. That's really blown smoke. What they're concerned about is new federal revenue. So where might you get this money? Well, there's a long list of possibilities. I've listed 6 of them here. We could increase income taxes, which many commentators, most prominently Warren and Sanders, are not enthusiastic about. We could increase capital gains tax. Capital gains are currently taxed at a much lower rate. We could use employer or employee payroll taxes. We could use a federal sales tax, or as they do in Europe, use a value-added tax. That's the principal source of revenue for paying for government health programs in France, Germany, and the UK. We could increase corporate income tax. That could be done by raising the tax back to 35% from where it was put in 2017 down to 21%. We could also tax the foreign earnings of corporations. Those earnings are not taxed now. And we could charge fees to large financial institutions based on their covered liabilities. In other words, how much debt they have. Why would you do that? Because large financial institutions, Citicorp, Solomon Brothers, and so on, are deemed by the government and by the society in general as too large to fail. And so they get bailed out. Well, should they pay for that? They are in effect insured by the federal government. And we could add many more. In my paper, I've selected 11 possible sources, and adding up the revenue that could be raised by using all 11, you can get enough money, 23.7 trillion to be specific, to cover the amount of new federal revenue needed. But that's just my choice of 11. Almost any author would have a bit different choice. So I'm not going to go into that here. If you're interested, you can take a look at the paper. So concluding here, how much will Medicare for All cost? Meaning, how much will U.S. healthcare cost under Medicare for All? What would be the increment? Well, the short and accurate answer is that the cost would be nothing, be less than nothing, because currently we are overpaying by 5.7%. But because households and insurance companies would not be paying anything under the new regime, new federal revenue would be needed to cover what they currently pay. But this new revenue is not the cost of Medicare for All. Medicare for All is simply the whole of U.S. healthcare, and its cost, therefore, is simply the cost of U.S. healthcare, which would be less than it does now. And so the bottom line is cost is not a barrier to adopting Medicare for All. The barriers, I believe, are fear of the unknown and the threat of disruption, which means that the political road ahead will be very difficult, but we can just stop talking about cost. That's not an issue. I have included in my slide set references to all of the costs talked about here, plus my own paper on this topic. And there's been another paper written by Charles Kai, which comes to a rather similar conclusion, and that is cited too. I gather that Dana will include this slide set in what she sends out to everybody participating tomorrow. So thank you very much. Sorry I've run over time a bit, but I think we have just a few minutes for questions.
Thank you, Dr. Mossert. Yes, there's been a couple of questions that have come through, and if anyone has any additional questions, please post them in the Q&A box at the bottom. Let me go back here. So one question we had was, said, I am confused about the reduction in payment to doctors and hospitals. I thought hospitals would be better off because of global budgets.
Well, they could be. Let me step back a step. Jayapal's bill calls for global budgeting of hospitals. Sanders' bill does not. So it's, and that's a big difference between the two. Let's suppose that global budgeting for hospitals was adopted. It depends on where the level's set. If hospitals are budgeted very low, then they're going to be worse off. If they're budgeted high, they're going to be better off. And of course, nobody knows what would happen in the event that global budgeting actually was adopted. The two bills before Congress, for those of you who haven't taken a look at them, they don't have anything about money in them. Money is a separate matter. There would need to be a separate bill established or enacted in order to provide the money needed to pay for Medicare for All, and we don't know how that would work.
Okay, thank you. The next question that was submitted says, when new revenue is analyzed in studies, do the authors figure in being able to negotiate drug prices rather than the current reality of that being an illegal action?
Negotiate what prices? I missed the word.
Drug prices.
Oh, yes. Yes, they do. Absolutely. And as I covered in that slide that deals with assumptions, the decreases in drug prices that are reported in the 7 reports range from 10% to 40%. So there could be very substantial decreases. Mind you, drugs cover, or cost rather, about 10% of US healthcare currently. So the base number is, well, of course, it's trillions of dollars, but in the grand scheme of things, it's a relatively small amount. Much more money is available to be saved in the insurance administrative arena.
All right, next question. What are the downsides of gaining income from employers and employees?
Again, I'm missing a word. The downsides of what?
Gaining income.
Oh, gaining income. Yeah, I didn't list that in the list of possible sources of revenue, but it's real. If payment for healthcare by employers or employees is no longer required, then there would be more money in the pockets of the employers or employees or both, and that would mean that the amount of money on which they are taxed has gone up, and so there would be sources of revenue available through that mechanism for sure.
All right, here's another question. Would doctors be able to form unions under Medicare-for-All?
There's nothing said about that in the either of the bills. The experience in other countries is that they do not form unions, but can't say what might happen here.
Are there studies or slides that if we are all covered with a single payer system, would our car insurance be greatly decreased?
I don't know. I never thought about that. Yeah, there ought to be some effect because car insurance currently covers medical expenses due to car accidents. I haven't thought about it. I would just be speculating here.
Okay, let's see. So I don't know, I think there's a little confusion. Why do you call it Medicare-for-All rather than Healthcare-for-All Minnesota? And I have Medicare, but in addition, I have to pay a supplemental fee to UCare. So I'm assuming that might be a Medicare Advantage kind of situation, or?
Yeah, it sounds like it. I didn't deal with a Medicare Advantage issue here at all. The administrative costs for Medicare Advantage are quite a bit higher than 2.3%. That complicates the whole picture. But under Medicare-for-All, there wouldn't be a Medicare Advantage program anymore. It'd be pointless because everybody would be covered. And the entirety of my report deals only with the national level. Please don't infer anything about what Medicare in one state, either Minnesota or any other state, would cost. That's a different matter.
Yeah, I think in general, it can be quite confusing because of the private insurance getting involved with Medicare, with the Medicare Advantage plans. And of course, Medicare only has an 80-20 breakdown in people by supplemental insurance and things like that. So
right, that's right. But again, all of that's gone under Medicare-for-All. Everybody's covered, period.
I think I'll maybe just do one more question since in consideration of time.
Right.
So this says people would still need to know what they actually pay. That is, now there are Medicare monthly payments plus the Advantage monthly payments, which we just kind of talked about. And she says, I understand those would be eliminated, but there would be taxes to pay towards the needed revenue from the federal government. What is the balance? So I think she's talking about what out of pocket for a family, for a household. What do you have any kind of sense about a bottom line cost kind of difference for a family?
Well, nobody knows because the taxing options are so broad. It's possible that ordinary income tax levels would be increased for people of all incomes. It's possible that there could be an increase in payroll tax above what's currently charged for Medicare. There's a Medicare payroll tax currently. We just don't know. In my paper, I very carefully chose 11 sources of revenue that would not result in any tax increase for any but the very wealthy. In other words, people with incomes over $150,000 a year. Warren, in her proposal, did the same thing. It is possible to use this change in social policy to partially redress the inequalities of income that we currently have in the United States by taxing the rich quite a bit more and not taxing anybody else more. That's what I would favor. But where it will actually turn out, nobody knows at this point.
All right, well, I think we're going to have to move on. Thank you so much, Dr. Mosser. We'll
Thanks for
see
the
if we can,
opportunity.
thank you. We'll see if we can answer any unanswered questions maybe in our post-webinar email, if we're able to do that.
Sure, I can help you with that, yeah.
Great. Thank you
Okay,
for all your questions
thank
and
you.
for our attendees. And then now we're going to move on to Ann Jones. So let's see, we'll get the video all situated here.
Hey.
Hi, Ann. Are you able to get your slides back up?
Yes. Tell me what you're seeing.
We need to start slideshow and then you're going to have to advance. Oh,
Okay.
there. It's at the right spot.
All right. Thank you, Dana. Thank you, Dr. Mosser. That was wonderful. Actually, it's the third time I've heard it, and I learn something every time. All right. I'm going to talk a little bit about our Education and Outreach Committee work. As you know, the COVID-19 pandemic has precluded many of the ways we were reaching out to the public up till now. So we've had to turn to the options like we're doing right now, virtual speaking events, and we have been a little bit precluded from doing a lot of the outreach that we had been doing in the past with tabling at events such as town halls, park events, and other conventions and so on. So we've had a group of very committed people, primarily from Healthcare-for-All Minnesota, working on programs, and many of you, I believe and I hope, have signed in and attended those programs over the spring and summer. We have a couple more in the works as well. Our committee meets online every 1 to 2 weeks to plan events. And we held 3 webinars that turned out to be pretty popular over this summer. Most of them have been at a noontime. Attendance is actually going up a little bit, and we're pleased to say that we can actually reach more people virtually than we can often in our in-person events. We chose to focus on the Fix-It video shorts with some also some basic health policy information presented, and of course a call to action. We are marketing to email lists and via social media. We really hope that when you get invitations for events, our educational events, that you will reach out to your personal networks and organizations you're familiar with and people you know who are with us on this issue, and share these events. That's part of being an activist. So we are kind of using our online education as our outreach as well to add to our numbers. I also did a couple of individual events. I had some invitations from some previous meetings with people to Senate districts in Minnesota. Happened to be, of course, they were DFL Senate districts, and got an invitation to do a slide presentation and a question and answer, and we can do more of that. This is a very flexible format. We can either have a meeting where everybody gets to participate or do a webinar type format. So please be kind of thinking about how we could use this tool to reach more people. And for organizations you are part of who are still continuing to meet probably virtually and need a program, this is a great way to provide a program. So please contact us via the Healthcare for All Minnesota website. You can put a message in. Dana monitors that, and we can get back to you and you know, plan to expand this option for education. So our content so far has been a combination of speakers, panels, videos. We are open to other ideas and content for speaker suggestions. Again, submit those to the website. Our previous educational events are on our YouTube channel. If you don't know yet, we do actually have a YouTube channel. So take a look and see if you can find that. Some of our information is also on our website. So then, just Rose mentioned the direct action that we did. As you know, we're on kind of a dual track toward getting everybody health insurance via public health insurance. And one track is working on a Minnesota health plan, so a state-based health plan. The other track would be a federal plan, such as Dr. Mossy just discussed. And National Nurses Union, of course, is really central and probably the heart and soul toward the work toward a federal Medicare-for-All, improved Medicare-for-All. And this was just a little action that we did. Like I said, we're kind of precluded from in-person events, but we chose to participate, and we did have a sign holding in 5 locations. I'll highlight people who really helped plan this, and I hope I don't forget anyone, but Dave and Rosanna Garibaldi took our North Metro area and created an event. Dawn Tuvison and Carla Sands helped us with a presence over in the East Metro. Cheryl Quick and I and Linda Gridley and Bruce Larson, and we recruited some people, and we covered 3 locations in Minneapolis and St. Paul, the Lake Street Bridge and over by the Marion Park Library. It actually was fairly easy to do, and we might consider doing it more to get visibility. Lots of traffic, 95+% people who responded, you know, were with us on this, got a few hecklers, but it's actually kind of fun and easy to do. So we did that, and then that we did 1 in-person tabling thanks to our board member, Mary T. Another little free advertising for Crooner's Lounge. They're doing outside concerts up in Fridley, and we met some great people, and our Instagram creators were from that event. So we felt that was well worth it. Let's see, a few announcements of events coming up. Our next one will be September 23rd, again, the noon time. And Senator John Marty will present, and we've asked him to present, maybe dig into the details a little bit on the Minnesota Health Plan. Now, that would be a state-based health plan. If we can't get Congress to move, you know, we're gonna work on moving something here in the state. And also, Ken Engelhardt and I are planning to talk on how to vote, being a healthcare voter, and some advocacy, because how to vote is going to be kind of key this year, as well as to vote. Please, Rose is going to talk a little bit more about a call to action, but do continue to call, write, and respond to our action alerts. See, check the calendar on our website for other meetings and events, and also please notify us of events that we should be promoting around the state, because we can do that. And there you go. Anything you think we should publicize. All right, that's my pitch.
Okay, thank you, Anne. We will get Rose set up here for the next part. Hang on. Hi, Rose. Oh, I guess we're on mute. Sorry. Somehow you're on mute. Do you have your audio, Rose? Okay, wait. All right, try it again. Nope, not hearing you. Is it your headphones? Nope, we're still, wonder what happened with your microphone. Anything? No, I'm not hearing you. Is anybody else able to hear Rose? Is it perhaps me? Wait, I thought I heard you, Rose. Can you say test or something? Okay. No.
Would you like me to pinch hit a little bit until maybe Rose can
Oh,
double check
sure.
the technology? Usually we asked Rose to give us a call to action today because I'm often the voice of this piece, and we thought maybe you'd be interested in hearing another voice on this. If you're around me at all, this is Ann again. I talk a lot about educate, organize, and legislate. Well, this cycle, the election 2020, is just an extremely important cycle. Everybody agrees about that for different reasons. I thought I'd make a little pitch for everybody getting involved and helping out campaigns so that we can, to do anything in Minnesota, it's going to be about flipping the legislature to a health and human services friendly legislature. Rose, are you on?
I think so.
All right.
Yes, we hear you, Rose.
Okay, I'm so sorry. I don't know what happened there all of a sudden, but we continue to play with this technology to make sure that we're able to use it appropriately. So I'm going to do this a little differently, and I'm not sure what Ann was saying because I couldn't hear, but I'm going to take this from a little different perspective. So most of you know me as the executive director of the Minnesota Nurses Association. You know me as a healthcare justice activist, and you know me as a workers' rights advocate. You don't know me as a domestic violence survivor, a former single mother, and a former welfare recipient. I share this with you because we all have a story, and because that story is what shapes our values. It moves us to do the things we do personally, like having children or not, getting married or not, professionally, furthering formal education, learning a trade, dedicating yourself to public service. And then there's activism, saving Mother Earth, maybe it's affordable housing, racial equity, or like all of us here today, healthcare justice. We have the great fortune to be experiencing history in the making right now. This moment is so critical for this country's future, it really cannot be understated. Now is our chance to flip the narrative on this myth of scarcity, that resources are extremely limited and one group's gain is automatically another group's loss. Let's instead talk about our collective abundance. We have the resources, but we need to strengthen our political will. Because our vision can't be achieved in a system that falsely says either healthcare or infrastructure, either jobs or environmental regulation, either schools or tax cuts. We can and should fight for the world that we want, for ourselves, for our loved ones, for our future. It's the International Year of the Nurse. Florence Nightingale, born 200 years ago this year, said to us how very little can be done under the spirit of fear. No more fear, only courage. No more despair, only hope. No more idling, only action. By pivoting our healthcare justice activism, we focus our courage and hope and action on the upcoming elections, because doing so means we strengthen the Minnesota House and flip the Minnesota Senate to ensure the passage of the Minnesota Health Plan by 2022, while also keeping strong progressive single-payer congressional leaders like Representative Ilhan Omar in Washington, D.C., and yes, working to elect Joe Biden as our next president, because even though he doesn't support Medicare for All, we can push him to get him to sign the state-based Universal Health Care Act so Minnesota can lead the way in guaranteeing health care for all, and the movement can continue to build under a democracy that must be saved. So what can you do? Campaigning is going to look different this year due to the pandemic. But guess what? You can phone bank from your lazy boy chair in your living room. You can text bank from your favorite patio chair on your deck. You can write brief messages on postcards from your kitchen table. We have a chance to win single payer here in Minnesota. Find a candidate who's running on supporting the Minnesota Health Plan and who's including Joe Biden on their ticket, and volunteer, volunteer, volunteer as much as you possibly can, because courage, hope, and action must prevail. And you can see on the screen that we have some, ideas: phone banking, sign holding, banners, postcards. Door knocking is probably not going to happen as much. There may be some very, very specific targeted, socially distanced, masked, appropriate type of door knocking, but most the campaigning is going to be done via phones and texting and, as I said, postcards, mailings, etc. But however it is that you are able to volunteer, and whatever amount of time you can give, please, please consider doing so we can move forward and begin to work on guaranteeing health care for all. And I think you've got one more slide that you wanted me to mention. Not this one, because I think I already spoke to this one. Did you want me to deal right now with the advocate for emergency expansion on Medicare and the emergency bills? So here are a couple of things you can do right now. So there are two bills in our Congress that are being debated. And one is called the Medicare Crisis Program. This is in the House. It's Jayapal and Kennedy are the authors. It would provide Medicare Parts A and B coverage to any U.S. resident eligible for unemployment insurance in the midst of this horrific pandemic, in addition to the fact that we are seeing an economic crisis as well in this country. Not having safeguards in place for people to access health care is not only inhumane, it is dangerous, and it is a public health risk. There is also the Healthcare Emergency Guarantee Act in the House and the Senate. Jayapal and Sanders are the authors. This would provide coverage for all necessary care, including prescription drugs, for anyone who is currently uninsured, but also cover out-of-pocket costs for those with health insurance. This is an incredible bill. It would be wonderful to see this passed and enacted, once again, to ensure everybody can access the health care they need when they need it, specifically to the global pandemic that we are in the midst of right at this moment. So I'm going to go ahead and post a link in the chat so that everybody can see a really, really terrific graph that was put together by the Physicians for a National Health Program that spells out the three different bills, because there's a third one which really just advocates for coverage of COBRA, and that one is not, in our minds, as good, because COBRA is kind of a mess. It's still tying people to health insurance, and we'd rather see people just simply get guaranteed access to health care. So it compares the three bills on a couple of components: coverage model, cost sharing, eligibility and enrollment, duration, and other provisions that are important to note. So I'll put that in the chat, and then you all can use that in your talking points when you call and ask our United States senators and congressional representatives to please support these bills. Thank you.
Thank you, Rose. All right, we're working on some video adjustment here. Well, that wraps up our meeting for today. Thank you so much for attending. This meeting has been recorded, so we will be putting this on our YouTube channel for you to rewatch or share with others. And again, I'll remind you that there will be an email sent to you and anyone who registered for this webinar tomorrow. And it will contain a variety of resources, links related to much of what we've talked about today, including Dr. Mosser's slides and those types of things. So please look for that. And thank you again for attending. You're welcome to exit the meeting. Thank you.